how are you? Zara, good
How are you?
morning. Tuli, how are you?
Good morning.
Good, thank you. How are you?
Hi. Himara, good morning and welcome to our chat. Thank you for joining us.
Thank you. Good morning.
Thank you. Okay, guys. I think we can begin. We're 2 minutes on past time. Please, Liz, please watch out for participants that are coming in. So I
Yes.
just want to welcome everybody to our first ever webinar. And for the purpose of this, we're covering the last 3 days in terms of our go-to-market, but primarily we're covering a more bigger issue of why healthcare matters to Africa. So for purposes of introduction, my name is Sydney Gondwe. I'm the founder of AfriPharm Health. And the reason why here is because across Africa, we keep hearing the same words, out of stock, or stockouts, as popularly known. Hospitals say they do not have enough medicines, government increased budgets, donors continue to support health systems, warehouses stay full, yet patients are still told to come back tomorrow. So we have to ask the hard questions, right? Is Africa truly running out of medicines, or are we running out of visibility? Well, this week we had 3 broken points in terms of whole pharmaceutical data claim journey, in terms of what the hospitals cannot see on their shelves, and then from a regulator point of view, what is it that they don't see that crosses the borders? And today we are basically saying, look, the patients usually do not have any visibility in terms of knowing what they've been given in terms of medications. So today, live, as we're going live in this room, what we want to do is we obviously calling out what the problem is and what it looks like. And then from there, what we'd like to do is I would like to start with a single global reference point. And that's because, you know what, the problems in Africa, especially in terms of health systems, as we know them, there are code systems, even though they're manual, they didn't start with us. So fragmentation seems to be a global view. And this we can see from the continent, whether we're talking about Accra, whether we're talking about Lagos, Abuja, or, right down to Johannesburg or to Lusaka, Zambia, the issues are all the same. So today, what I'd like to do is obviously with this hour long is include 5 voices who will give us real answers and get into exactly what we're here for. I'd like to introduce the panel. First, we have Lucy Zara Kongwa. She's our managing partner of AfriPharm Health UK. She'll give us a brief but most powerful global reference in terms of the point she's going to open in relation to prescription services in relation to fragmentation. We have Solomon, our country founder and agency director for Ghana. We have Tuli, our country founder and agency director for South Africa. And we have Elizabeth, our country founder and agency director for Zambia. And joining us with a very robust experience and who's currently in the thick of things in terms of policy and data is Ms. Ayanda Kuneni. She's a pharmacist. She's also she holds a master's in global health policy and also a University of Edinburgh and Mandela Washington Fellow. Guys, I'd like to welcome you guys to this chat without wasting too much time. First of all, Lucy, before we go to Accra, Johannesburg, and Lusaka, just 4 minutes of your time. One of the most powerful arguments of why we built AfriPharm is building, or rather why we're here, is basically founded on the fact that there's this fragmentation in data. Now, you have the NHS in the UK, which is one of the most, considered one of the most global standards in terms of healthcare delivery. Ayanda was actually in the UK. She'll be able to also share one of our experiences from the partners of what they're building in South Africa on that. But from your point of view, could you please just tell us quickly, more or less, what are your experiences in terms of the NHS fragmentation, and then where you see the opportunities in Africa in terms of the challenges that we have? Thank you. Lucy, I don't know whether you heard my question. Hello, Lucy, can you hear me? Can you guys hear me?
Good morning, everyone, and welcome. Hello.
Yeah,
Can
we
you
can
hear me?
Yeah, we can hear you.
Boy. Hello, can you hear me? Yes, I can.
Yes, we can.
Yes, ma'am, I can hear you.
Yes, we can hear you.
Can you hear me?
Yes, we can.
Good morning,
Yes, we can.
everyone, and welcome. Thank you for being here. Okay, great. So I'm just going to, okay, fantastic. So I was going to say, I've been given the honor of opening today's conversation. So I'm basically here to give you the context that makes everything, because the voice and real solutions from across the continent. Oh boy, what's happened? Hello, I'm really sorry, my network's. Hello, can everyone hear me?
We can hear you.
Yes, we can.
No.
Okay.
Yes, I can hear you.
Sorry, yeah. I was going to say, before everyone else, I just want you to understand exactly why we've come here and why this is so urgent and why the timing of what AfriPharm is building is everything. So I'm going to take you back, not to Africa, not yet. I'm going to take you back to the United Kingdom, one of the most expensive lessons in health history. So this is what we call the NHS story. In 2003, the UK government launched the most ambitious health IT ever attempted. The goal was simple: connect hospitals, unify records, give everyone one clear view of the system. The budget was 6.2 billion. Unfortunately, the final, because what they were trying to do was connect hospitals, clinicians, and regulators that had been in existence for IT people in one room, in one office in central London, and they'll be able to build one system that will speak the same language for all these fragmented hospitals, clinicians that had been around for so many years. This was one of the most expensive public IT failures. But one thing is, it didn't fail because the vision was wrong. The vision was actually right. It failed because they tried to unify a system that had already fragmented. Thousands of hospitals, hundreds of procurement teams, dozens of regulators, all running different data, different standards, no common language. By the time they tried to connect it, the roots had gone too deep. It took 18 more years, 2 failed attempts, and billions more pounds before the NHS data strategy missed in 2003. So now, here's why I'm telling you this. Africa is not yet there. Hospitals are growing, supply chains are scaling, regulatory frameworks are forming, the data infrastructure layer, the invisible layer that makes everything else work, is still being decided right now, today. So this is not a disadvantage for Africa. This is a once in a generation opportunity to build it right the first time. Before the fragmentation sets in, like it had many years ago for the UK, where over 50 years, hospitals had their own system, they had their own language that they were using. So before the roots go too deep, before the bill reaches 12 billion, like it did for the NHS, this week, AfriPharm named 3 uncomfortable truths. Hospitals don't know what's on their shelves. Regulators don't know what's crossing the border. Patients don't know what they're taking. These are not uniquely African problems. They're exactly what the NHS faced and spent 2 decades and 12 billion learning to fix. AfriPharm is building what Africa deserves, not retrofitting a Western model. They're not adopting legacy technology, building right, building first. The NHS learned its lesson the hard way at enormous cost over many years. Africa doesn't have to, because AfriPharm is turning those lessons into infrastructure that works from day one. 5 voices from the ground are about to show you exactly how. Sydney, the floor is yours. Hello, Sydney.
Thank you for that, Lucy.
Hello.
Yeah, I can hear you. Thank you so much for that great opening, and obviously experiences from the NHS side in terms of the UK. At this point, I'd like to take us to Ghana. Solomon, we actually at a pivot in terms of what's happening in Ghana related to FDA story of West Africa's most established regulatory frameworks. And I believe you guys have the NHIA, which is among the oldest on the continent, and yet the data gap still persists. What are your experiences in terms of this fragmentation? And just walk us through the inventory blindness in terms of what that looks like for hospitals. Take us through the broader question in terms of Ghana's position in the West African corridor. And obviously, finally, what is or who is Ghana's patients standing at the pharmacy counter look like? What does that look like for Ghana in terms of its position in West Africa?
Okay. Good morning, everyone. It's a pleasure to be a part of this webinar. And today I bring you greetings from Ghana. We say, to welcome all of you, we say Akwaba to everyone. And well, to quickly talk about the questions that Sydney, Mr. Gondwe just asked. So in Ghana, we have the FDA, we have the NHIA, and then we also have other regulators that take care of when it comes to medications and when it comes to drugs in Ghana. Now, a typical picture of how the gap between the drug data is like this. On a morning at a hospital, a nurse goes to the hospital trying to dispense medicine or try to get medicine across to a patient, only gets to the dispensary and realizes that the shelf is empty. There is no drug. So what they do is that then they have to refer the patient to go and get the drug from another place, probably a nearby pharmacy or a chemical shop. So once that person moves away, the dynamics begins to change. Now, before the hospital then gets drugs again to its stores, like the hospital gets drugs to it has to go through some processes. And most of the times there are a lot of delays when these happen, because the nurse will now have to report to whoever is the head of the dispensary. The head of the dispensary will have to now report to the officer in charge of the entire government hospital. Then the person also in charge of the government hospital will now have to report either to the district level or to the regional level. Then the regional level will now have to put in procurement for the drugs. Now, we used to have a store, a medical store in Ghana. I think some years ago it got razed by fire. And as we speak, I think either they are currently working on it or they are trying to look for an alternative. Now, with the process that I just mentioned some seconds back of reporting the drugs to the final, the final person on the reporting line, by that time, sometimes it takes months for this report to actually get to the final person on the line. So what happens is that then the dynamics change, because by the time it's getting to the person at the top, there have been several other people who have also come, probably in need of that same medication. But because they've been turned away, whenever they come, they are no longer going to depend on what the hospital is going to give them. But once they take the prescriptions from the hospitals, they go straight to the nearby pharmacy or the nearby chemical shop to get the medicine. So then by the time the drugs is being procured and being sent down through all the various steps downwards again to the hospital or to the government hospital or to the clinic, then the dynamics would have changed. So then now these drugs or this particular drug in question can be on the shelf for a very long time and will even get expired. So then this becomes the gap. There is no real-time data actually making the procurement or whoever is reporting to be able to give a clear picture of what is happening on the shelf. Okay, so I mean, I'm doing some talking. Let me share my screen basically so that we could see. I have a little presentation here. I want to share my screen for us to have a clear picture about yes. Okay, so please, I believe everyone can see what I'm sharing.
Yes, we can.
Yes.
All right. Okay, so this is what happens. So Ghanaian hospital procurement leads the order based on unreliable consumption records. So sometimes it could take months or even weeks to actually procure a particular drug. Now, when these drugs are procured, they are also given out based on request per the hospital, per whichever government hospital does sends in the request. So if there is no request, it means that the drug will be at the central stores and end up getting expired and getting wasted, which also becomes another cost. Now, aside this, we also want to look at how Ghana becomes the hub for some of these, especially for counterfeit drugs. Now, if you look at this map, or as you can see on your screens, you know, Ghana is let me just say, is almost around the center of West Africa. And literally everything, most of the time, goes through Ghana. Now, there are physical checkpoints which are in the country. And then there are issues of visibility or where these people bring in the drugs, but then there are no checks, especially at the borders. Now, this is where the danger is, because FDA in Ghana, we know, is doing a lot. That's the Food and Drugs Authority. They are trying to do a lot to curb the influx of counterfeit drugs. But what is happening is that there are challenges. One of the challenges they face is that they are only able to know that there is an influx of a particular drug when people make complaints that they bought this drug and this is the reaction they are having. And then the other issue is that they have to now accumulate data to be sure that this, to be able to have a certain trend before they look at what they have to act about. Now, one of the things that happen is that when some of these drugs are passing through Ghana to its destination, when it passes through Ghana, they are presented as goods. They are presented as how do we call it? They are presented as goods that are fragile. So, in order not to incur costs, they let some of these or most of these things to just pass through the country to other points. And by so doing, these people that are transporting these counterfeit drugs, one of the things they do is that they deposit or they leave some in the country. And the pharmacies and what we call here as drugstores or chemical sellers, because in Ghana, there are two. We have the pharmacies. They have a certain way of operating, and then we have the chemical shops, or popularly called the drugstores, which are the small pharmacies that you can have around, like very small. So it is just in terms of size, and each of these two have a certain capacity that they are supposed to operate under. Now, when these guys do the transit and drop some of these drugs in the country, what they do is that they have people who are buying them. They have people they are connected to. So regulators cannot see, and therefore they don't have control. They will only be able to see when there is a trend of a particular trend of let me say, of symptoms, because people have taken certain drugs or a certain side effect. So that is where the issue now comes in. Okay, so Ghana is still doing a lot, but I feel that if things could change, it could help us to curb or be able to fight some of these things. Now, in Ghana, when it comes to the patient is the market woman. The patient is your next door neighbor. The patient can be yourself. The patient is somebody who has a discomfort and is in a hurry to get a relief. So what do? The first point of call is either the drugstore or the pharmacy. Now, when we go to the pharmacy, we trust literally everything that the pharmacist is going to tell us, or whatever the chemical shop owner is going to tell us. We literally trust everything. So we don't care about what they are giving us. All we are interested in is that what they've given us will work. And at the end of the day, we must see some results. Now, we are not able to do any verification from the drugs we buy. And this is just a little data. It says that 18.7% Africa carries the highest global prevalence of falsified and substandard medicines. Then when it comes to, that's where the gap is, which is the information vacuum. It says that 12.4% and 19.1% prevalence of substandard antibiotics and malarials across African markets. And annually, about 170,000 child deaths from pneumonia caused by falsified medicines in LMICs. Okay, so most of the time, what the patient doesn't know is this drug safe? Is it a counterfeit drug, or is actually what it is? Now, one other thing too is that people, in trying to find comfort, in trying to minimize costs and not to spend much, are always interested in getting what is cheaper. So when you go to the pharmacy or you go to the drug stores, one of the things that happen is that they give you options. So if you want to buy paracetamol, that's in Ghana. I don't know for the other countries. They'll tell you there is this brand, there is that brand, there is this brand, there is that brand. Now, the question is, do we know if all these brands are certified or they are approved even by the FDA in Ghana for their sale? Now, I personally have had an experience where we entered a pharmacy to get a drug. And when we mentioned the drug that we're looking for, the pharmacist had to now go behind his shelf. There was a small room which he went behind and now brought out the drug. And I was puzzled, So in my being inquisitive, I later on met a friend who was a pharmacist, and I asked, why do pharmacists do that? I said, oh, it's because the drug they are selling, whichever one they are bringing from their hideouts or those small rooms, are drugs that have not been approved by the FDA. I'm like, then they are killing the people. It's like, yes, it's because most of the time people prefer to buy certain things. Okay, so basically we trust the pharmacies, we trust the chemical shops, and that is it. We don't have any tool to verify if what we are taking is actually genuine, is going to harm us, or is actually going to give us a cure. Now, the problem was never the medicine. It's always data. There is a missing layer. There is something that is missing that is not making us to actually know what we are looking for, or what we are supposed to get, and why there are these medicines on the market. Now, the data to prevent medicine shortages, block falsified imports, and verify patients care already that already exists. It is just not connected. We do not need more silos. We do not need more central medical stores to keep drugs closer. No, what we rather need is an infrastructure that will connect all these central stores together. Now, when they are connected together, then we have data. We'll have a real-time update. So now there wouldn't be a long process of reporting to whoever is supposed to be reported based on the reporting hierarchy at the top. It wouldn't take a longer time, but they can also know that, oh, okay, so let's say a hospital in Accra is getting low, or there is let's say just a box of antibiotics, so they need to be supplied, and we are supplying this drug, or we are supplying an antibiotic based on the approval of the FDA, and this drug is what we are using all over the place, or we are using for every other hospital. So we just need that space, and that is what AfriPharm seeks to do, and that is what AfriPharm is doing, and that is what AfriPharm has actually built. So it's just the missing layer. So this is the architecture of the visibility gap. So the actors, you see the actors, so the hospital procurement, that's Ghana, the blind spots, ordering based on siloed, outdated consumption data. Now, because it takes a longer time for the top hierarchy to receive and then make procurement, sometimes it takes months, it takes weeks, and it could even take probably a year for some of these things to happen. So it's one of the reasons why a lot of people in Ghana don't really trust the NHIA, which is the National Health Insurance Authority. They don't really trust them, because even though some of the care will be taken care of, when it comes to medications, you will go and then you realize that you can't find some of the medications. So you are forced to go and buy it from elsewhere. Now, buying this from elsewhere is where the chances, whether you are taking what is going to help you or the same thing that is going to actually cause other problems. Now, the next thing is, so the AfriPharm infrastructure is actually the pharmacy partner network connected to the NHIA. Sorry. Now, what is the pharmacy partner network? The pharmacy partner network is where every other pharmacy sits on when it comes to AfriPharm, and is connected to the NHIA, and they are able to have real-time data of the stocks that the pharmacies have, of what drug is moving where. In fact, there is traceability to the last consumer. So from the pharmacy that the drug is coming from, to the person it's being given to, or the person that is requesting or buying the drug, to the final consumer, or whoever is going to take the drug. Now, when there is an issue, we will be able to trace this, because there is a connection between the pharmacies and the NHIA. Now, the next actor is the FDA Ghana, which is the Food and Drugs Authority, and other regulators. We have the Pharmacy Council and so on. Now, the West Africa Corridor Data sieve, that's the blind spot. Because what happens is that when these falsified drugs are being transported, in the fear of cost, most of it are not checked. They are not checked, and then they just enter into the countries. Their deposits are being made in every other country that these drugs is passing through, or every border that is passing through in West Africa, until it gets to the final destination. Now, by the time it's getting to the final destination, every other thing has been deposited. So it's just left with a few that will get to the final destination. All because these drugs or these things are presented as fragile and expensive and all that. So in order to save cost and the fear of having legal issues, they allow these goods to go through without knowing what actually these goods are. And sometimes they even wrap them in different items. They keep them in boxes of other things. Yes. Now, the AfriPharm infrastructure seeks to have a blockchain supply verification and the FAR standard. Okay. So what happens is that right from where the drug is from the manufacturer to the person transporting to the country is going to, then verifications that are done to its final destination, everything can be traceable, everything can be seen, everything can be found, and there is no missing gap. Now, this will help us to know if whoever is manufacturing the drug is actually manufacturing the required standard drug, or is falsifying the whole thing, or is actually selling something that is not supposed to be sold to the innocent consumer. Now, the final actor is the Ghanaian patient. Total reliance on trust without objective verification. Harm from unverified care and medical tourism decisions. Now, that is where another AfriPharm feature also comes in. That's the health vault. And then Dr. Cheerful, which is our AI, our medical AI, who is very interesting to have and to interact with. So with the health vault and Dr. Cheerful, you are able to verify what you are taking. You are able to be sure what you are taking, know the side effects. You know, some drugs come with side effects. You're able to know the side effects. And through the health vault and Dr. Cheerful AI, you are able to be able to know what is happening to you. If it is the effect of the drug, it will ask you to report to the hospital, let them know that this is what it is. The health vault also helps you to keep track of all the drugs that you have taken and your medical records. So in case of any emergency, they are able to, the hospital that is going to take care of you will be able to track everything about you and your health record. Okay, so Mr. Gondwe, I believe that I have been able to answer most of your questions, but I'll be on standby if there are any more questions.
Yeah, you've actually outdone you've done more than answering all the questions that I'd actually posed to you. Thank you so much for giving us a West African perspective there, Solomon. Without further ado, I'd like to basically bring in Tuli from South Africa. Tuli, I think with South Africa, everybody would like to understand the regulators view. The South African Health Regulatory Authority. This is one of the most sophisticated private healthcare markets on the continent. And maybe take us through what the public-private data divide is in South Africa, and what does it actually cost in terms of medicines. And then let's look at where does the South African patient public facility experience. After Tuli, what I'd like to do before we go to Elizabeth is bring in Ayanda, because what we're doing is we're connecting a story here. But Tuli, take it away, please.
Okay, it's my turn. Can you hear me clearly?
May I please ask Elizabeth to mute? I think there's some sound coming from her side.
Um, so who's Mike?
Elizabeth.
Oh, okay. We'll tell her that.
Thank you.
Thank you.
Okay, can you hear me?
Yes, we can. Take it away, please.
Okay. I wasn't sure. I heard you mention Ayanda. My network is quite shaky, so I'm not sure if it's Ayanda's turn or it's my turn.
No. It's your turn. I was just connecting that when you're done with your perspective before we finish up with Elizabeth, is I'd like to go and open it our questions to the audiences. I'd like Ayanda to take in, make the case, because I think you guys are on parallel in terms of she's done more or less a lot of data analytics behind this. So Tuli, take it away.
Okay, thank you for the opportunity. I would have loved to share a presentation, but my computer keeps telling me about settings that I need to go through, but I'll just I'll go through quickly what I have here. I'll just walk you through a process. So we are one of the most sophisticated markets on the continent of South Africa. In terms of drug data and safety, we have SAHPRA, which is the South African Health Products Regulatory Authority. It's one of the 6 regulators in South Africa to achieve the World Health Organization maturity level 3. Now, we have a private healthcare sector that rivals anything in the global south at the moment. We also have the NHI, which was signed into law. So basically, we have the language, we have the legislation, and we have the institutions. Yet, I'm going to give an example with Chris Hani Baragwanath in Soweto, because it's one of the biggest, largest hospitals in South Africa and in Africa. A nurse in Chris Hani Baragwanath in Soweto once reached for adrenaline in August 2023, and the shelf was empty. Africa's largest hospital ran out of adrenaline for 2 days full. And that's what keeps, people alive. It's not a supply failure. It was actually a data failure. They failed to manage their stock because they don't have any system, any infrastructure that manages that data. Solomon has covered most of that. So I'll just go through what the data in South Africa shows. And I want to be precise because I'm in a room with people who deal with evidence. So between May and June 2023, an organization called Richide and the Stockouts Project, they documented 404 stockout reports across 72 public facilities in Northwest Province alone. In the Eastern Cape, there are doctors who could not treat bone marrow cancer patients province-wide because there was a chemotherapy shortage. These are not isolated incidents in South Africa. They're a pattern that repeats over and over, province by province, and each and every year. So I was looking at a study that was done by BMC Health Services Research, where they found 8 public facilities in KZN that had stockouts that affected 85% of the 392 medicines tracked. And on the other hand of that same number, 50% of medicines were overstocked and some even expired. That's wastage, and it's sitting in one facility, while another facility 3 districts away or in the next suburb, it's run out of stock, but it's sitting in reach of them. You know what I'm saying? So no system flagged that, and no connection existed to prevent it. Now, the financial cost of that is not abstract either. Research published in the Frontiers in Medicine, they found that a huge number of the urban public hospitals in South Africa lost over 700,000 rand to expired medicines in a single cycle. So that's just one hospital. Multiply that across the 400 plus public hospitals running in the same fragmented inventory systems. And you understand why this is not just a patient safety crisis. It's also got a fiscal impact, and it's a procurement problem. Now onto the NHI. Our president, Cyril Ramaphosa, signed it in on the 15th of May 2024. It's law as we speak. So it's not a policy aspiration anymore. It's a legal commitment to universal, comprehensive, and quality healthcare for every South African. So the fund will purchase services from both public and private providers across all 9 provinces. Think about what that requires. It just needs a single payer fund purchasing medicines and services from thousands of accredited facilities, and it's supposed to do that on inventory data that pharmacy managers in peer-reviewed research have described as fundamentally unreliable. It's fragmented, and you can't use that for ordering decisions. Now, the NHI, it does not create a funding mechanism, it creates an infrastructure requirement. And that infrastructure it requires is verified dispensing data, it's real-time visibility across public and private points. And at this present moment in time, the NHI does not have that type of infrastructure at scale. So this is the single biggest data gap standing between the legislation and what it actually promises to patients. But let me tell you then where this lives at the most human level. Because everything I have described so far is systems language, and we need people language now. So according to the stats essay, the General Household Survey of 2023, we only had about only 3 in every 20 South African who have access to medical aid. That means when the public sector shelf is empty, there's no alternative. There is no private pharmacy fallback, and there is no safety net. There's a queue, and then the patient gets to an empty shelf, and then the journey home with nothing. So that means medication, patients are defaulting. So a cross-sectional study found that 231 facilities reported 609 stockouts of essential medicines over 3 years. And 78% of those were antiretroviral medication. Now, South Africa runs the world's largest ARV program, and the system managing it cannot consistently see what it has on its own shelves. So stockouts are, okay, so the study describes stockouts as, and I'm going to read this directly, stockouts as normal despite the substantiative efforts of treatment interruption. It's not exceptional. It's not edge cases. It's normal. They use the word normal. It's the most damning word in South African healthcare right now because that cannot be normal. With that being said, South Africa, it does not need another report naming this problem. The report exists, the evidence is overwhelming, and what it needs is the connection layer that makes the data visible, actionable, and accountable in real time across public and private facilities before the shelf empties. And this is what Solomon has extensively covered about the AfriPharm Health Pharmacy Partner Network, which is not only a medicine tracker, it's a live standardized data infrastructure which links verifies dispensing points so that what is on the shelf is visible before it becomes a crisis. So that overstocked facility can be connected to the understocked one before the expiry date passes. And so that's the NHI fund has the verified dispensing data it needs to actually function. I touched a bit on SAPRA. So it has a traceability roadmap that identifies full unit level serialization as a destination by 2031. But AfriPharm Health already has that visibility layer from the ground up today, right now. So the problem was never really medicine, and South Africa proved that at scale with data and an enormous human cost. It was always data, and the infrastructure to fix it is being built right now. I can hand the floor over to you, Sydney.
Thank you so much, Tuli. As I said earlier, you've actually done an opening gambit and a place for Ayanda to come in. I'd like to, Ayanda, from a collaborative aspect, first of all, you've just heard from Accra, Johannesburg. Before we finish off with Lusaka, Zambia, I thought that from your perspective as a practicing pharmacist, what does the frontline reality that Solomon and Tuli have just described to you look like inside the profession? As a global health policy scholar, why has the infrastructure conversation take this long to arrive at on the continent? I know you and I basically shared a lot about this information in terms of stockouts, especially in South Africa, and then you've had the great exposure of, between your studies in the UK and South Africa, especially from a public sector to private, to have an overview of what does it take to bridge that gap in terms of adoption, and just share with us your experiences in terms of, the whole stock out in terms of fragmentation.
All right. Thank you so much, Sydney, for the opportunity. Thank you so much for the invite. I'd like to firstly welcome everyone on here. And as Sydney has briefly shared, my name is Ayanda, and I am a practicing pharmacist. And as he's also shared, I've had the fortunate experience of being exposed to different types of healthcare systems, right? So in South Africa, I've worked in the public sector, I've worked in the private sector and in the NGO space. And then during my studies abroad, I've had the fortunate opportunity of being exposed to the NHS, which is the healthcare system in the UK. So part of the things that I realized and learned is, as South Africa, as much as we can say that we have made strides in improving the healthcare sector, I think that those strides are mainly in the private healthcare sector. We have one of the best healthcare sectors, as my predecessor has spoken about it, Utuli. I think there's a lot of work that needs to be done, and I think that can be done through collaboration. I think the biggest gaps that exist are gaps and opportunities that exist can be found through collaboration from the public and the private health sector. I say this because there've been policies or programs that have been implemented, such as the CCMDD program. For those of you who don't know, that's the Centralized Chronic Medicine Dispensing and Distribution Program. So what that does is it allows patients from the public sector to collect their medicines from the private sector. While all of these things are available and the technology and the policies are available, I think, as Sydney has asked, some of the biggest gaps that are there are, I'd say, in my opinion, political will. I think the technology is there, the resources are there, the funding is there, but we have a lot of gap when it comes to political will, because it does not make sense that in 2026 we don't have systems in the public sector that speak to each other. I think this is evidenced by the fact that the CCMDD project provided us with the evidence that it's possible if there is the political will. Another thing that I've been exposed to is most recently, I met a gentleman from the UK, and he runs an app. It's called Repix Connect. So what Repix Connect is, it links the doctors. So firstly, I'll say this works properly in the UK because of the NHS system, right? Which is the biggest healthcare provider. So what Repix Connect does is it links the doctor and the pharmacist. So before the patient goes to the pharmacist after their consultation with the doctor, they already know which pharmacy has the stock available. And I think it's apps or implementations or technologies such as these ones that could help move South Africa forward. I also think, and I'm actually like really impressed by the work that is done by, institutions like AfriPharm. And I think the biggest thing is we need to have pharmacists in the room. We need to have pharmacists in the room when these conversations are taking place, particularly for like NHI or in the designing of apps, because pharmacists are the ones who are going to use these apps at the end of the day. Pharmacists are the ones who are exposed on a daily to the challenges, and they are the ones that speak to the customers, to the patients rather, on a daily basis. So I think the biggest gap also in the implementation and the design of these systems is to have the actual people who are going to be using them. And that means having pharmacists, in the room to have these conversations. So I would say, to answer your question, Sydney, the biggest thing would be political will, would be involving the stakeholders who are going to be involved in the implementation, and not just the implementation, but the design of these programs. And yeah, I think a lot of the conversation I had with you, Mr. Gondwe, a few weeks ago, and I think we don't lack the infrastructure, we don't lack the funding, we just lack the political will. Yeah, that's my opinion. Thank you.
Wow, thank you so much, Ayanda. And this is the reason why I wanted you to bridge that gap after Tuli. It's because we almost have speaking the same language in terms of everything is in place, but how do we connect the dots? To finish up, before we open questions to our audience, we're going to now ask Elizabeth, who is our country founder for Zambia. Please land the plane for us and give us your perspective, especially our interest, having covered everything we have. What does a country that cannot fully see what is crossing its borders experience at community level pharmacies? We're talking about, what do your average patient, basically, Zambia is basically a landlocked country. How drugs get into the country. I mean, we have fragmented pharmacies in terms of community and hospitals. And then if you look at the patient vacuum in terms of what the patient doesn't know what is your experiences basically in terms of the whole pharmacy fragmentation in relation to, remember, the data, the gap that is actually fragmenting the whole process. Thank you. Elizabeth, it's your turn.
Can you hear me? Hello?
Yes, we can. Please proceed.
Yeah, hello, we can hear you.
All right. Thank you so much for this opportunity that you have given me. I want to talk about two things that I pinpointed that are really an issue in Zambia as a country. And these two things are the last mile and the data vacuum in Zambia. So firstly, before I go, I just want to talk a bit on your question, Sydney. So let me start with a simple reality. A patient walks into a clinic in Lusaka, the doctor writes a prescription, the patient goes to the pharmacy, and the pharmacy does not have medicine in the shelves. So they try another pharmacy, then another, eventually they either give up or delay treatment, or they give up on their process of healthcare. Your question, I would say pharmacists make decisions with limited visibility because they don't really know what happened at the first point. Hello? Can you hear me?
Yes, we can. Proceed, please.
Yes. I also just want to talk about the vacuum, which is a bigger problem also in Zambia. If we go deeper, the last mile problem is not just about the logistics, it's about the missing data. We call this the data vacuum. A data vacuum is when systems exist, transactions happen, patients are treated, but no usable or connected data generated or shared. So they're basically disconnected. There is no continuity of data from the borders to the pharmacies onto the patients. So consistent medicine, quality, usually there is outstock in the pharmacies. And yes, so to continue, I also want to talk about what AfriPharm is here to solve. Using the pharmacy partner network, most of the things have been touched by Kekeli and Tuli, but I just want to touch as well because I have noticed that it has also really affected the healthcare system in Zambia. So AfriPharm is here to bridge the gap that has been broken for quite a very long time in most countries and in Zambia specifically. So using the pharmacy partner network, AfriPharm is here to connect pharmacies into one system. It is here to enable real-time stock visibility. It is here to reduce the last mile inefficiencies using the healthcare vault, which stores patients' records digitally, allowing the patients to have control over their data or over their information. So a mother choosing medicine without full guidance is as a result of the last mile problem that we have in Zambia. Patients will either choose to continue with treatment or they delay with care. Yes, any other questions I'm ready for?
Basically, I think that's it. We wanted basically for you to give us your view and right on time. At this point, I would like to open up the stage to if there's any further clarifications on contributions to the audience, or maybe anyone in the audience would like to share their perspective in terms of the data fragmentation when related to access to drugs. And I think I just wanted to actually just more or less if the audience these figures, up to 500,000 people in sub-Saharan Africa die every year from falsified substandard medicine. This is the part that Solomon from Ghana was talking about. This includes over 267,000 deaths linked to fake anti-malaria drugs, which is up to 169 deaths linked to poor quality antibiotics. This is basically from the Economic and Social Council organization.
Sorry,
World Health Organization.
can I just say, yeah. Elizabeth, okay, she's muted. That's fine because there was, yeah.
Okay. Then there is the World Health Organization estimates that at least 1 to 10 medical products in low and middle income countries is substandard or falsified. Again, we have this low to middle income countries who lose over $30 billion every year due to falsified substandard medication. Maybe what's glaring for me from all this data that we're sharing, whether from the World Health Organization or from CDC Africa, I would like to open the stage now in terms of your in-country experiences that please lift up your hand if you'd like to contribute, and then open up the stage for you to basically give us your overview. And please, let's take in cognizance of time under 2 minutes, and if you'd like to ask a question, limit it to that as well. Thanks. All right. Okay, Nathan, you want to ask a question? Please go ahead.
Good morning, everybody. My name is Nathan. I'm a student at Texila American University in Zambia, and I have primarily 2 questions on the patient side and as well as on the student side. Firstly, this question is to Accra, Johannesburg, and Lusaka, of course. On the patient side, what's the most feasible way to give patients real-time access to drug identity using this solution, right? The second question would be on the student side. I believe there's some students here as well, medical students. And my question here and my concern is what are the entry points, or are there any entry points in existence currently, let's say for students, clinicians, to contribute to building this particular infrastructure? Thank you.
Okay, thank you. Who would like to tackle that? Solomon, Elizabeth, Tuli, Zara, which one of you would like to tackle that?
Sydney,
Okay.
I'll tackle the second question.
All right, go ahead.
Yes,
Go ahead.
with regards to students, right?
Yeah.
So Nathan, I'd say when it comes to students, the entry point or the opportunity that's available for there, and it's obviously like institutional, like the university, would be in the design of the pharmacy training program. I think most institutions that provide pharmacy training need to also encourage an entrepreneurial or like an innovation type of courses when designing the program, because there is a need for students to not just to be clinical, but to also have their minds along the mindset of how can we address these challenges that we're going to come across when we get into practice. Thank you.
Thank you so much for that, Ayanda. Solomon, you wanted to add to that?
No, I wanted to answer the first question by Nathan.
Yeah, please go ahead.
All right. Yeah. So when it comes to the patient side, what AfriPharm seeks to do is to do all the due diligence for the patient. So once you are using the pharmacy partner network, any pharmacy that is on the AfriPharm platform has been will have to will be verified, will go through all the necessary regulatory processes. And that is where we do know your customer, because we have to be very diligent about it. Now, the other part is that we will also work with regulators like the FDA in Ghana to be sure that, okay, they have approved these drugs to be sold in Ghana because it meets the standard or it's not a falsified medicine. So all the clients or the patient needs to do is to make sure that they are using the platform, and whatever is they are getting from the platform is of quality, is not falsified, and they are safe to take it. Just like the way, even without the system, they are already trusting the pharmacies. Okay, now this time around, we are doing the due diligence for them, and we will give them reports on what is happening, so they know that whatever they are taking in or whatever they are requesting for is not falsified, but it's actually what it is. Yeah, thank you. I hope I answered it right.
Thank you so much. So thank you for that, Ayanda and Solomon. Is there any questions or contributions from the panel that from the discussions about drug data, or your personal contributions you'd like to make in terms of your in-country challenges that you have, and how you're seeing that whole policy gap being addressed? Okay, if there are no, is that a question? Okay, none? Okay, so maybe we would like to wrap up. I'd like to just ask everyone who participated to give a closing remarks. I'll start with, shall we start with Elizabeth this time? Elizabeth, any closing remarks?
I would say thank you so much for joining us, and please join us for the next meeting that we are going to be setting. I hope you had a wonderful time. We love you from Zambia. Thank you.
Thank you, Elizabeth. Thank you, Elizabeth. Let's go to Zara. Zara, any closing remarks or contributions you'd like to make?
Just to say thank you to everyone. Thank you for being here. And I would say, I think closing remark is that AfriPharm is building the solution Africa deserves, like I said earlier. And I don't think there's anything like it anywhere. So we're heading in the right direction and hoping not to make the same mistakes that the UK did many, many years ago. So yes, thank you to everyone.
Thank you, Zara. Ayanda, any closing remarks, contributions that you'd like to make, or additions or clarification? The floor is yours.
Right. Thank you, Sydney. I'd like to say thank you to everyone for joining us today. Thank you, Mr. Gondro, for the invite. And I'd like to say that as pharmacists and as someone who's on the ground, we appreciate the work that AfriPharm is doing. And I look forward to the work being scaled and, addressing a lot of the pressing challenges that African healthcare systems fail. So thank you.
Thank you so much, Ayanda. Finally, Tuli, any closing remarks, additions, or anything else you'd like to contribute from our discussion?
I'd firstly like to thank everybody for participating in today's webinar. I think what we've seen today is clear. We don't have a medicine problem. It's a visibility and a trust problem, if I can use those words. So my takeaway is that the moment we can see what exists and we can verify it and connect it in real time, we'll then move from reacting to shortages to preventing them altogether and making sure patients are taking the correct medication. So drug safety is really important. And our conversation today just showed that there's no drug safety as per se, and AfriPharm Health is here to bridge that. Thank you.
I'd like to take this opportunity to thank everybody that took part and joined us today. This is our very first webinar. We believe in answering, giving solutions to African problems. We believe that, if there's going to be any solutions, if anything has showed us in the last 18 months in terms of donor aid to Africa, is that Africa needs to find its own pathways. And this, we know that with the fragmentation, we needed the resources in terms of what is that connects healthcare across the continent, but we start at communities, regionally, and so forth. Thank you so much. You may proceed at the time of your convenience. We'll do a recap of today on the AfriPharm Health company profile webpage on LinkedIn. We have socials across Instagram, Facebook, TikTok that you may follow and just keep up in terms of the preview of what is happening. And of course, we welcome collaboration from all of you. We believe in building collaboration. This is why we built AfriPharm as an API heavy product where we can connect and use obviously the first interoperability resources in terms of how quickly we scale the product. We thank you that you are actually the best person on the ground who understands your solutions and how we mitigate that. And as African as we can be, we believe in the Ubuntu that what's that word again? It takes a village to raise a child. We believe it would take a village to basically connect care. And we're nothing without you. Thank you so much. Join us next week, same time. We take a look at a different segment of our webinar in terms of not a data crisis, but in terms of the whole entire administration of healthcare in Africa. Thank you so much and have a blessed Wednesday. Thank you.
Thank you.